All right, good afternoon, everyone. My name is Jeremy Lund. I am a member of the EM and Critical Care Clinical Forum, and I will be your CE moderator for today's presentation. Our CE today is a presentation by the Emergency Medicine Critical Care Clinical Forum within FSHP, and this is going to be our post-Florida Residency Conference research webinar. So this CE is being put on by two selected PGY1 and PGY2 pharmacy residents presenting their emergency medicine and critical care related research projects that they presented at the FRC. This is meant to share this knowledge throughout the state. So as a former preceptor myself of many research projects, I know that not everyone is able to attend the Florida Research Conference, but there's a lot of really good research that's being presented there and ideas that can be shared across the state. So 3 years ago, we started this CE after FRC to showcase some of that material that's being presented at the conference to a more statewide audience. So just for full disclosure for everyone to know, these four speakers were selected by being the highest scores representing PGY1 and PGY2 of emergency medicine and critical care research. Those scores are calculated and abstracts being evaluated by folks outside of the state of Florida, so not biased by anyone from within the state. So these are independently validated and vetted best research abstracts submitted for the Excellence in Research Award. So to introduce today's speakers, I'm going to go ahead and introduce all four of our speakers and then let them present back to back to back to back. So our first speaker will be Dr. Shania Monk. She is a PGY1 pharmacy resident at HCA Florida Ocala Hospital and a member of the hospital's first residency class. So congratulations on being an EIR finalist and presenter here in your first year of having a residency. During her residency training, she's focused on critical care topics, including her research project. Today, she'll be presenting on the risk of intracranial hemorrhage between tenecteplase and alteplase with mechanical thrombectomy for acute ischemic stroke. We will then hear from Dr. Caitlin Helwig. She is a PGY1 pharmacy resident at UF Health Shands Hospital in Gainesville. She'll be continuing her training there as a PGY2 critical care pharmacy resident, so congratulations. Today, she'll be presenting her research on ceftriaxone administration and early ventilator-associated pneumonia incidents in patients with traumatic brain injury and multisystem trauma. We will then switch it over to the PGY2s, and we will first hear from Dr. Tana Smith. He is from Claremont, Florida. He attended undergraduate at Florida Gulf Coast University in Fort Myers. He then went to the University of Florida College of Pharmacy at the Orlando campus. He's completed his PGY1 pharmacy residency at UF Health in Jacksonville and stayed on there for his PGY2 in emergency medicine with professional interests including resuscitation, trauma, toxicology, and pediatrics. His resident research project this year examines the impact of intravenous phenobarbital loading doses in patients with moderate to severe alcohol withdrawal. And finally, we will hear from Dr. Cheryl Wood. She is a PGY2 critical care pharmacy resident at Lee Health in Fort Myers. She graduated from the University of Florida College of Pharmacy and completed her PGY1 pharmacy residency at Lee Health's Gulf Coast Medical Center. And so with that, I will turn it right on over to Dr. Monk.
Hello, so today I will be presenting on the risk of intracranial hemorrhage between tenecteplase and alteplase with mechanical thrombectomy for ischemic stroke. At this time, me and my co-investigators have nothing to disclose. And here is a list of abbreviations that will be used throughout our presentation. The objective of today is to describe the current guideline recommended therapies for acute ischemic stroke and compare their dosing strategies. When looking at stroke, it is a leading cause of long-term disability and death, and in the United States, there's roughly 800,000 cases per year. Of those cases, 87% can be attributed to a thrombus. Current AHA/ASA guideline recommended treatment therapies include thrombolytics, also called fibrinolytics, and mechanical thrombectomy. For our fibrinolytics with thrombolytics, we have alteplase and tenecteplase. Current guideline recommended dosing includes 0.9 milligrams per kilogram with a max of 90 milligrams for alteplase. This is given as a 10% IV bolus over 1 minute, and the remainder is given over 1 hour. Tenecteplase dosing is 0.25 milligrams per kilogram with a max of 25 milligrams, and this can be given as a single IV bolus. When we compare these two thrombolytics, Alteplase does have a shorter half-life and as such can be given as a bolus infusion. With tenecteplace's longer half-life, it can be given as a single bolus, and tenecteplase has a potential cost benefit. This cost benefit also may go down or improve more with its recent approval from the FDA for stroke. And at our facility, sorry, at our facility, we did switch over to tenecteplase because of the cost benefit and its ease of administration. Next slide. Currently, the risk of intracranial hemorrhage is one of the main primary safety concerns, and nationally it's been described as a rate of 2 to 6%. In this study by Warich with 9,238 patients, they compared alteplase versus tenecteplase with the primary outcome of symptomatic intracranial hemorrhage. 3.6% of the alteplase group versus 1.8% of the tenecteplase group experienced symptomatic intracranial hemorrhage. This was statistically significant. Not all patients underwent mechanical thrombectomy, though. 20% of the alteplase group versus 38% of the tenecteplase group. This was statistically significant. Next slide. And in this study by Hendricks with 635 patients, all patients in this study did undergo mechanical thrombectomy. They also looked at symptomatic intracranial hemorrhage as the primary outcome, and with alteplase 3.2% experienced symptomatic intracranial hemorrhage versus 3.4% in the tenecteplase group. This result was not statistically significant. So, next slide. With these differing statistical significances in symptomatic intracranial hemorrhage, as well as at our facility, with the switch over to tenecteplase, our providers subjectively felt that they were noticing more bleeds with the use of tenecteplase. So our study wanted to compare and evaluate the incidence of intracranial hemorrhage in acute ischemic stroke patients who underwent mechanical thrombectomy and received alteplase versus tenecteplase. This study was a retrospective chart review with a 1-month washout period to allow for the facility transition between alteplase and tenecteplase. Alteplase was compared with between August of 2022 to August of 2023, and tenecteplase between September of 2023 to September of 2024. We used alteplase with standard dosing in mechanical thrombectomy and then compared it with tenecteplase standard dosing in mechanical thrombectomy for our study design. Patients were included if they were 18 years or older, had an acute ischemic stroke, received tenecteplase or alteplase, and underwent mechanical thrombectomy. Patients were excluded if they had anything that increased their risk of bleed, including anticoagulant therapy. If they did not, if they had received dual antiplatelet therapy and tirofiban, and then if they did not complete a full dose of thrombolytic, if they were pregnant, or if they were incarcerated. The primary outcome was intracranial hemorrhage per radiographic imaging up to 36 hours after mechanical thrombectomy. And then secondary outcomes included symptomatic intracranial hemorrhage as defined by radiographic imaging of intracranial hemorrhage and a baseline change in NIH stroke score of up to or equal to 4 points during or up to 36 hours after mechanical thrombectomy. We also looked at discharge disposition and death during index hospitalization. Statistical analysis included a significance of an alpha of 0.05. For our continuous variables, we had Mann-Whitney U-test, and then for our nominal variables, we had a chi-square or a Fisher's exact test. 94 patients were screened, 66 were included, 33 in the tenecteplase group and 33 in the alteplase group. The primary reason for exclusion was dual antiplatelet therapy and tirofiban. Of our baseline characteristics, our median age was 75 in the tenecteplase group and 78 in the alteplase group. Our male age was 52% was 17, and then 52% was 17 in the alteplase group. And then our primary race was white with 67%, and then 70% in the alteplase group. None of these results were statistically significant. And then for our past medical history, our primary was, as you can see, the hypertension with 25 or 76% in the tenecteplase group and 25 or 76% in the alteplase group. None of our past medical histories was statistically significant. And then for our last baseline characteristics, we had a baseline NIH score with 17 in the tenecteplase group and 18 in the alteplase group. Our time from last known well to thrombolytic administration was a median of 95 minutes in the tenecteplase group and 85 minutes in the alteplase group. And then time from thrombolytic to groin puncture was 43 minutes in the tenecteplase group and 39 in the alteplase group. None of these were statistically significant. For our primary outcome of intracranial hemorrhage, 8 patients had an intracranial hemorrhage in the tenecteplase group for 24%. And then 9 patients in the alteplase group were 27%. This result was not statistically significant. For our secondary outcomes of symptomatic intracranial hemorrhage, 5 patients in the tenecteplase group experienced a symptomatic intracranial hemorrhage and 6 in the alteplase group. Our primary discharge disposition was inpatient rehabilitation facility with 13 in the tenecteplase group and 8 in the alteplase group. Tenecteplase had 0 deaths and alteplase had 4. None of these results were statistically significant. The primary limitations of this study was its retrospective nature. It did have a small sample size as well as our 1-year comparison. We were thinking that we were going to have more patients in our study, but with only having that 1-year comparison due to our switchover timeline, we did expect more, but unfortunately was not able to have more patients. So in conclusion, based on this retrospective study for acute ischemic stroke patients who underwent mechanical thrombectomy, there was no difference in the incidence of intracranial hemorrhage between tenecteplase versus alteplase. And so for our self-assessment question, we have, based on current guideline recommendations, which of the following best describes the dosing of alteplase versus tenecteplase for the treatment of acute ischemic stroke? We have tenecteplase given as a continuous infusion with 0.4 milligrams per kilogram, and alteplase with 0.9 milligrams per kilogram with a bolus plus infusion. Alteplase as a continuous infusion with 0.9 milligrams per kilogram, or tenecteplase with 0.4 milligrams per kilogram with a bolus plus infusion, or tenecteplase as a single bolus with 0.25 milligrams per kilogram, or alteplase with 0.9 milligrams per kilogram with a bolus plus infusion, or alteplase as a single bolus with 0.9 milligrams per kilogram, and tenecteplase as 0.25 milligrams per kilogram with a bolus plus infusion.
C.
Yes, it was. So here are my references. And then I would like to thank my research members at HCA Florida Ocala Hospital. And today I presented on the risk of intracranial hemorrhage between tenecteplase and alteplase with mechanical thrombectomy. Thank you.
All right. Thank you very much, Dr. Monk. Do we have any questions from the audience? You can either put them in the chat or unmute yourself.
Just curious with the sample size for this particular retrospective review. Was that like the normal amount of patients that this hospital system usually sees? Was it slightly unusual, or is that just your normal amount?
I believe in terms of, for this study, because we had to have a thrombolytic plus mechanical thrombectomy, this was a little bit lower. We are considered one of the top facilities for stroke, and we do have a pretty high average of patients who come in with stroke and receive a fibrinolytic. But because this study also had fibrinolytic plus mechanical thrombectomy, that lowered our numbers.
And there was no consideration for including the thrombolytic only group?
We were primarily looking at the risk of adding tenecteplase with mechanical thrombectomy because of what our providers were subjectively feeling. They were noticing more bleeds with the tenecteplase group, specifically with mechanical thrombectomy.
Okay, got it.
All right. Any other questions for Dr. Monk? All right. Well, thank you very much for your presentation.
Great job.
Yeah, great job. Thank you. We will move along to Dr. Helwig.
Good evening. My name is Caitlin, and I will be presenting on ceftriaxone administration, looking at early VAP incidence in patients with traumatic brain injury and multisystem trauma. Myself nor my co-investigators have anything to disclose for today's presentation. And the presentation objective for today will be to describe the role of antibiotic therapy to prevent early VAP in patients who have experienced a traumatic brain injury. Looking at a little bit of background information, we know that patients with TBI and multisystem trauma are at an increased risk for ventilator-associated pneumonia. We do know that antibiotic prophylaxis has the potential to lead to shorter ICU and hospital stays, decreased duration of mechanical ventilation, as well as increased ventilator and antibiotic-free days. However, we do need to consider the disadvantages of antibiotics, which include C. diff infection, as well as the potential for increased resistance. There are a couple of previous trials that looked at the use of ceftriaxone to prevent early VAP in brain injury specifically. We had the PROFI-VAP trial, which looked at a single dose of ceftriaxone to prevent early VAP, and they did find a significant difference, at least a decrease in early VAP incidence with those patients. In addition to that, they did find that there was a decrease in duration of antibiotic and ventilation use, as well as mortality at day 28. And then overall ICU and hospital length of stays by day 60. And then there was another smaller study conducted by Lewis and colleagues looking at the same intervention, although they did allow the use of levofloxacin in the place of when a beta-lactam allergy was present. They also found that this decreased early VAP incidence in that specific group, but this, as we can see, these two studies primarily looked at acute brain injuries. So as we look into our study, we wanted to add the component of multisystem trauma. At our institution, we do have a guidance for the antibiotic prophylaxis use with ceftriaxone specifically. The patients that we see this in are those that have a type 3 extremity fracture, which is defined as an open fracture with a wound greater than 10 centimeters with extensive soft tissue injury or amputation. And then this ceftriaxone is started within 1 hour of injury and continued at least for 48 hours after skin closure. So our study objective was to compare the incidence of early VAP between mechanically ventilated TBI and multisystem trauma patients who were given ceftriaxone versus deferred or no antibiotics within 12 hours of intubation. This study was conducted at a level 1 trauma center, which consists of 1,135 beds. The 2 ICUs that this study looked at were both 24 beds, which were our neuromedicine ICU as well as our trauma ICU. This was a single center retrospective cohort study with patients admitted between September 30th of 2020 and September 30th of 2024. Our first group was ceftriaxone within 12 hours of intubation, and then our second group was no or deferred antibiotics, but we did allow the use of perioperative cefazolin in both groups. We included those that were 16 years of age or greater with a TBI plus other trauma that required ICU admission, a GCS score of less than 12, and then they had to be mechanically ventilated for a minimum of 48 hours. And then we excluded any of those patients that were intubated 48 hours after they were admitted if they had a tracheostomy, a prior hospital stay within the previous 30 days of that index hospitalization, and if they were transferred from an outside hospital or if their injuries were deemed non-survivable. In total, we had screened 387 patients. We ended up excluding 297 of those, with the primary reasons being mechanical ventilation of less than 48 hours, as well as non-survivable injuries. And then we ended up with 31 patients in our early ceftriaxone group, which was that group that had ceftriaxone within 12 hours of intubation. And then we ended up with 59 patients in our no or deferred antibiotic group. Our primary outcome was the occurrence of early VAP, and then secondary outcomes include the occurrence of late VAP or VAP relapse, ventilator and antibiotic-free days at day 28, length of stays in both ICU and the hospital, the incidence of C. diff infection, and then the microbiology of that early VAP infection. Early VAP was defined as a patient receiving at least 5 days of antibiotics after a positive BAL culture, which was collected within 2 to 7 days of intubation. Late VAP was a positive BAL culture collected 7 or greater days after intubation and received antibiotics. VAP relapse was at least one of those causative bacteria from a previous VAP infection that grew in a BAL that was collected between 48 hours and 14 days after completing a 5-day course of antibiotic from that previous infection. And then C. diff infection was defined as a positive C. diff PCR, as well as receiving active treatment with either oral vancomycin or fidaxomicin for a minimum of 48 hours. Our primary outcome was analyzed via Fisher's exact test, and then secondary outcomes for categorical outcomes were analyzed via chi-squared or Fisher's exact test, and the continuous outcomes were analyzed via student t-test or Mann-Whitney U. Looking at our baseline characteristics, we can see that the median age of both groups range between 40 to 44 years old. We primarily had white males included in this study. And then whenever we look at the operative prophylaxis use with ceftazoline, we can see that around 61% of the ceftriaxone group received ceftazoline, and then around 49% in our no or deferred antibiotic group received ceftazoline, but this was not statistically significant. And then looking at our early ceftriaxone group, the median number of ceftriaxone doses was around 4. Next slide. And then we did have one significant baseline characteristic, which was our injury severity score, with our early ceftriaxone group having more severe injuries than our no or deferred antibiotic group, and we'll discuss this a little bit later. Looking at our pneumonia outcomes with that primary outcome of early VAP, we can see that there was a numerical decrease in our early ceftriaxone group. However, this was not statistically significant. And then as we can see here, our late VAP and VAP relapse outcomes also were not statistically significant between groups. Looking at our secondary outcomes, again, we can see that ventilator-free days and antibiotic-free days at day 28 were not significant between groups. The length of stay in ICU and hospital were also not significant between the two groups. And then C. diff infection was also not statistically significant between our two groups. Looking at the microbiology of that early VAP infection, we can see that the most common bacteria seen were either methicillin-susceptible Staphylococcus aureus or Klebsiella species, as well as Haemophilus influenzae. And we did have 6 patients in our no or deferred antibiotic group with greater than 1 organism grown in that BAL culture. So in conclusion, we can see that there was no difference in the incidence of early VAP between groups. However, as I mentioned before, we did have a significant difference in our injury severity scores, which may have decreased the likelihood of being able to detect a difference in our outcomes. What was interesting is that our antibiotic-free days were similar between groups, but overall, this does provide data on the impact of prophylactic ceftriaxone on VAP outcomes in a real-world trauma population. There are some limitations to consider with this study, one of those being its retrospective design. We did allow the surgical prophylaxis antibiotic use, however, given how common that with these open fractures that they have to go to the OR to fix these fractures, we ended up allowing the use of ceftazoline in these cases. There was a variability in the number of antibiotic doses with that ceftriaxone group, as we saw. The median number of doses was 4, but could range from anywhere to 1 to 5. But previous studies only allowed 1 single dose. There was a potential for selection bias. As I mentioned, we do have some patients that will automatically get ceftriaxone at our institution. But there is a possibility that we had a lack of power with our study when performing a post hoc analysis. We had estimated that with our incidence rates, we would have needed around 200 patients in total to be able to detect a difference. So in conclusion, the administration of early ceftriaxone within 12 hours of intubation resulted in no difference in early VAP when compared to no or deferred antibiotics in polytrauma patients with a TBI. Some future directions to consider. Ideally, we could conduct this study in a larger study population. We would also like to look at the effective injury patterns to see if there was a difference there that may have affected our VAP outcomes. And then we would like to look into the impact of prophylactic antibiotic duration. As I mentioned, previous studies only had one single dose, whereas our study, we had a range from anywhere from like 1 to 5 doses. So for today's self-assessment question, what is the potential benefit of early ceftriaxone administration following intubation in patients who have experienced an acute brain injury? I'll give a few seconds. Yeah, and if you said B, a decreased incidence of early ventilator-associated pneumonia, you would be correct. I'd like to thank my co-investigators for their guidance as well as their help on this project. And at this time, I will take any questions.
Just one question. Can you hear me? Hello.
Yeah.
Hi, Caitlin. Thank you so much for that great presentation. That's a very interesting replication of the literature. My question was regarding the patient population. I know that they were all TBI, but I think, correct me if I'm wrong, the long fracture TBI, they were open fracture patients, so those were excluded, and then
those were included for the study.
they were included. Oh, the proportion of those. Was it like significant proportion of those? And then what is the antibiotic exposure for those?
Yeah, it's a great question. We did not collect on injury patterns, which was a limitation of our study. We just know that at our institution, we automatically are giving ceftriaxone to those with that type 3 open fracture. So without collecting on those injury patterns, I don't have an exact number for you in regards to how many we had in our population. But if there were any that had that type of fracture in this study, we would assume that they did receive ceftriaxone.
And then I thought I only had one question, but I apologize, I have more than one. My other question and my last question is, you mentioned the exposure to antibiotics being 1 versus more than 1. Did you stratify, just out of curiosity, to see how many of your patients only had 1 and what that looked like?
That was something that we did consider whenever looking at manuscript writing and things of that nature. I don't have the numbers exactly in front of me, but I believe whenever I did try to perform that analysis with the stratification, that I didn't see a difference. I don't know if that was just user error with the software, but at least whenever I ran that analysis with the help of some statisticians kind of close by, it didn't look like there was maybe a significant difference among like how many doses, but also considering our power, or our study may have been underpowered to begin with. I don't know that we would have found that difference with our study population size. So hopefully if we were to repeat the study and maybe have around 200 patients in total, we might be able to see a difference in that VAP outcome, but then also may be able to stratify based off of the number of ceftriaxone doses.
Thank you.
All right, any other questions for Dr. Helwig? All right, hearing none, we will thank you for your excellent presentation, and we will move on to Dr. Smith.
All right, thank you very much for that. So today I'll be presenting on the use of intravenous phenobarbital for the treatment of moderate to severe alcohol withdrawal in the emergency department. I just wanted to state that neither I nor my investigating team has nothing to disclose. And the objective of this presentation is to understand the advantages and disadvantages of using IV phenobarbital for moderate to severe alcohol withdrawal in the emergency department. So in our normal day-to-day life, our body carefully balances the inhibitory neurotransmitter GABA and the excitatory neurotransmitter glutamate. Next slide. And when we acutely consume alcohol, this enhances our GABA side, favoring the inhibitory side. Next slide. But over time, when the brain adapts to the consumption of alcohol, by downregulating GABA and upregulating glutamate receptors to get back into balance. Next slide. And when alcohol is abruptly discontinued, the previously suppressed excitatory pathway then becomes hyperactive due to GABA deficiency and excess glutamate activity, and leading to the signs and symptoms of alcohol withdrawal. Next slide. So the severity of alcohol withdrawal can range from mild to complicated and can be assessed utilizing the CWAL AR scoring tool, which is a 10-item scale used to assess and monitor the severity of symptoms. Like I said, ranges from mild to complicated, but CWAL scores ranging from 0 up into the high 20s. We can also utilize the patient's presenting symptoms to define severity. So if the patient is, mildly anxious versus moderately anxious, they have a severe tremor, and then all the way down to if they present with seizures or delirium. But one thing you'll notice about this is that utilizing the CWAS score and looking at the patient, use a lot of subjective determination to determine what severity they would be classified into. So there's two main treatment strategies for treating alcohol withdrawal, and this is the utilization of symptom-triggered benzodiazepines, which is typically lorazepam, and then there's also utilizing phenobarbital. And phenobarbital tends to offer many pharmacologic advantages over benzodiazepines, and this includes a non-GABA dependent mechanism of action, longer half-life, and longer duration of action, which allows for a more gradual tapering effect. So the data is limited on the ideal treatment regimen and dosing strategies. Next slide. So there was a study performed in 2013 by Rosenson, and it was a randomized double-blind placebo-controlled trial that looked at the utilization of single dose of IV phenobarbital, 10 milligrams per kilo, plus symptom-triggered benzodiazepines. And it was found that patients that received phenobarbital had fewer ICU admissions, and there was no difference in adverse effects. There was also a study performed in 2018 that was a retrospective review that again found that a single dose of IV phenobarbital, in addition to symptom-triggered benzodiazepines, for patients with moderate to severe alcohol withdrawal, led to more patients being discharged within 3 days in the phenobarbital group. Next slide. So the purpose of our study was to compare IV phenobarbital plus symptom-triggered benzodiazepines with alternative care in the treatment of moderate to severe alcohol withdrawal, and I'll define what our definition of alternative care is in the coming slides. So this study was performed at UF Health Jacksonville, which is a multi-campus academic medical center with nearly 800 beds, and it serves as a safety net hospital for Northeast Florida and Southeast Georgia, and primarily serves indigent population. This is an IRB single center retrospective cohort study, and we looked at patients from January 2015 through January 10th, 2025. Next slide. So patients were included if they were 18 years of age with clinical evidence of moderate to severe alcohol withdrawal, and if the patient received one of the following regimens. So first, our study group, the phenobarbital IV, given as one dose over 30 minutes, in addition to symptom-triggered benzodiazepines. If they received symptom-triggered benzodiazepines alone, or if they received an IM or oral phenobarbital load with symptom-triggered benzodiazepines. At UF Health, we do have our own intramuscular dosing strategy for phenobarbital for alcohol withdrawal. That includes a 6 to 12 milligram per kilo load of phenobarb given IM over 3 doses. And the dosing strategy from the 6 versus 12 milligrams per kilo is based on the patient's risk for respiratory depression. For the patients that are excluded, if they had a primary diagnosis other than alcohol withdrawal, they had an allergy to phenobarbital or benzodiazepines, severe liver dysfunction, respiratory insufficiency, if they were intubated prior to ED arrival, pregnant, or incarcerated. Our primary endpoint was to look at the total dose of benzodiazepines that were received within 48 hours, and this was used to be a surrogate for symptom control due to some patients not getting consistent CWAS scoring. And secondary endpoints included disposition from the ED, rates of intubation, ICU length of stay, hospital length of stay, mortality, and rates of adverse events. Next slide. So when we utilized the effect size from the Rosenson study I mentioned earlier and data from a previous in-house study, we found that we needed 198 patients to reach 80% power to detect a difference of 40% in administered benzodiazepines in 48 hours. And categorical data was described using chi-squared and Fisher's exact, and continuous data used Kruskal-Wallis. Next slide. So I screened 1,036 patients. I excluded 948 of those patients. Most of those obviously being due to that they were presenting to the ED for another diagnosis, whether that's for trauma. 21 experienced mild symptoms and 15 were incarcerated. I included 88 patients, 44 in the study group, and then 44 in the alternative care group. 30 of those received symptom-triggered benzodiazepines alone, and then 14 received the intramuscular phenobarbital plus symptom-triggered benzodiazepines. Next slide. So there was no difference in baseline characteristics between groups. However, I did want to point out that nearly all patients had a history of presenting to the ED with alcohol withdrawal, and approximately 40% of these patients had a history of withdrawal seizures. Next slide. And then when we look again at more baseline characteristics, we can see, if you go to the next slide, the ones that are highlighted are the statistically significant differences. So we can see that there are more patients in the higher CWAS score in the patients in the phenobarbital group, and there are more patients that experience tongue fasciculations as a presenting symptom of alcohol withdrawal in the phenobarb group as well. And then going on to the treatment characteristics specifically, when we go to the next slide, we can see highlighted the IV phenobarbital dosing. So the median dose is 780 milligrams. And then this was roughly 10 milligrams per kilogram based on ideal body weight and actual body weight. There were 8 patients that received an additional dose of IV phenobarbital, and this was roughly 6 milligrams per kilogram. And then if we go to the intramuscular phenobarbital, there were 10 patients in the study group that also received intramuscular phenobarbital. And again, like I mentioned, 14 patients in the study group and the control group that received intramuscular phenobarbital. And there was no difference between the doses in these patients. And then looking at the oral phenobarbital, we can see 14 patients in the IV group, and then 12 patients in the alternative care group received oral phenobarb. But again, there was no statistical difference between the groups. And if we look at the other treatments that received that might have altered CWAS scores for the patients, we can see that there is, again, no difference between groups. Equal number of patients received alpha agonists, antihistamine, gabapentin, and other things that would, again, alter our assessment of CWAS score. Next slide. So when we look at our primary endpoint, the dose of benzodiazepines received within 48 hours, we can see that there was roughly 80% decrease in benzodiazepines utilized, favoring the IV phenobarbital group, and this was found to be statistically significant. And this difference was actually found to be statistically significant at all time points. And if we go to the next slide, this slide again looks at the utilization of benzodiazepines for the patients. However, this breaks up the IV phenobarb group, the intramuscular phenobarb group, and the symptom-triggered benzodiazepine group alone. And we can see again that the IV phenobarb group received less benzodiazepines compared to both groups. And again, this was significant at all time points. Next slide. When we look at CWA-AR scores between patients, like I mentioned, the initial CWA-AR score was higher in the phenobarb group, and this was found to be, again, statistically lower at 6 hours, 12 hours, and 24 hours, again, favoring the phenobarbital group. When we look at ED disposition, we can see that there was a statistically significant decrease in patients who were admitted to the hospital, and favoring, again, the IV phenobarb group. And 11 patients in the IV phenobarb group were able to be discharged home after an observation period. Other endpoints pretty much included rates of adverse effects, rates of intubation, ICU and hospital length of stay, and death. And if we go to the next slide, you can see highlighted that there was a significant decrease in length of stay, hospital length of stay, favoring again the IV phenobarbital group at 3 days versus 5 days. So when we look at our results, we can see that the IV phenobarbital group was associated with significant reduction in benzodiazepines. And although that my study was not powered for the 40% reduction we were looking for, I did back calculate the power and found that we were indeed powered to find an 80% decrease in benzodiazepine utilization. Again, we can also see that it was associated with reduced CWA-AR scores, prevented hospital admissions, had shorter hospital length of stay, and there was no increase in adverse events. Next slide. We can see the limitations, again, the study being retrospective. There's also like a poor and inconsistent recording of the CWAT-AR scores, and this is probably just due to, maybe delay in ordering of CWAT-AR scores, and also, the ED is a very hectic place, especially at a level 1 trauma center. So you are depending a lot on the nurse being able to accurately and timely take the CWAT-AR scores in a busy ED. Again, subjective description of symptoms. So different nurses may have different variations of different scorings of the same patient at the same exact time of CWAT scores. There was an inconsistent dosing of IV phenobarbital. So typically we dose it 10 milligrams per kilogram based on ideal body weight. However, I noticed a lot of patients were getting either based on ideal body weight, actual body weight. Some were getting 10 milligrams per kilo as a single dose. Some were getting 15 milligrams per kilo as a single dose. So again, just inconsistent dosing there. And then there's also potential for variation and benzodiazepine conversion. I was doing all the conversions myself from all the benzodiazepines. And I used one chart, but however, when you look online, there's definitely various ranges of equivalents to benzodiazepines, but it was consistent from my end. If we go to the next slide, we can see that this study ended up allowing me to develop a protocol for the utilization of intravenous phenobarbital for the treatment of moderate to severe alcohol withdrawal. And this was really to facilitate the ordering of IV phenobarb from the ED providers and making sure that it's ordered with the correct dose, the correct weight, and is also ordered to be administered over 30 minutes as opposed to one of our orders that shows to administer as IV push, which can increase the risk of adverse effects. Allows them to also have included in their symptom-triggered benzodiazepines and an additional 5 milligram per kilogram dose of phenobarb if the patient is considered refractory, which the definition is down there to the left. So this, again, is a protocol that I've handed out now to our ED providers, and I was able to also build an order panel that is currently being built in Epic, again, to facilitate appropriate use. So to conclude, we showed that the use of 10 milligram per kilo IV phenobarbital load for the treatment of moderate severe alcohol withdrawal resulted in a more rapid and more prolonged symptom control, which decreased the utilization of benzodiazepines and also decreased hospital admissions and length of stay. However, I did want to point out that it is important that this is used in appropriate patients. So again, the patients in this study their primary diagnosis was alcohol withdrawal. They weren't a trauma patient that came in. It also happened to be an alcohol withdrawal. So just wanted to clarify that for sure. And then again, a protocolized approach is essential and may improve patient outcomes to avoid missed orders or misdosing of the phenobarbital. That takes us to our self-assessment question. The next slide.
Are you back?
Yeah, I'm back. Sorry
It's okay.
Sorry, what was the last thing you guys heard?
We're on the conclusions, I think.
Okay. So yeah, sorry. IV phenobarbital provided better, more rapid symptom control and led to reduced admissions, allowed more patients to be discharged home. I wanted to emphasize the use of this protocol and the correct patients. Again, these patients were admitted specifically for alcohol withdrawal as their primary diagnosis. They weren't a trauma patient that came in and also were in alcohol withdrawal. And then lastly, just pointing out that a protocolized approach may improve patient outcomes and avoid missed orders or misdosing of the phenobarbital. And that leads into a self-assessment question. So which of the following is a potential advantage to utilizing IV phenobarbital over benzodiazepines for alcohol withdrawal? And the answer will be A, longer duration of action. And I want to say special thanks to the UF Health Jacksonville Research Committee members, and then I'll take any questions you may have.
Can you hear me?
Yep, I can hear.
Oh, awesome. So Tanner, quick question. This is retrospective. Was this, were physicians in the ED ordering this as one-off orders, or was this out of an order set that you guys already had implemented?
Yeah, this was based on one-off orders. It was something that we noticed was being utilized more in our ED, which is why we decided to do this research project. And that's why I ended up developing an order panel to be implemented to allow the proper ordering and making sure that it's utilizing ideal body weight, 10 milligrams per kilo, and again, include the CWA scoring as well as symptom-triggered benzodiazepines and the appropriate vital sign monitoring. So,
oh, that's great. I know you said an order panel came out of this. Was there any, did you look to see if any physicians were tapering the phenobarbital at all, or was it just the loading dose and rescue?
yeah, so there were some patients in the study that received the large dose up front and then also received like an oral phenobarbital taper. Our thought behind utilizing IV phenobarb is that its long half-life and duration will allow it to self-taper, so you should forego the need of ordering that. But there are some physicians that still tend to order that. And I noticed that typically after the patient's admitted and it's the admitting team that decides to order that.
Okay. I know you're working on that protocol. Just be aware that there are some studies out that compare the taper versus the non-taper. And they're finding, no real difference between those patients who get taper and don't get taper. So you might be able to get away with that order panel instead of having to create a tapering process for them.
Yeah, correct. Yeah, we won't be the order panel won't include a taper for it. It's just the one-time 10 milligram per kilo dose.
All right. Very good. Thank you.
Thank you.
Quick question in the chat. Are you using RAS for this patient population at UF Health Jacks?
Yeah, that's a good question. We typically just stick with the CWA monitoring, at least in the ED. When it comes to when the patient's admitted, I believe they still utilize the CWA monitoring as well. I'm not sure that providers prefer to use RAS for this.
And I just want to ask one really quick logistical question. Are you having the phenobarbital 10 milligram per kilogram dose be made in the IV room and sent to the emergency department? Is someone preparing that bedside? How is that actually being made for some of these, like sometimes very sick and sometimes combative patients?
Yeah, we will typically make it at the bedside, and usually our providers and the residents and nurses, they're very good about reaching out to us if they have something like this come up. We'll either see the order come through and we'll go over there and make it, or the nurse will call us and ask us to come make it for them, or unfortunately, we don't have 24/7 pharmacist coverage, so we can't be there all the time to make it, but our nurses there are very good, and I trust them all to make this themselves on those off hours, but it would be nice to have us there 24/7.
Are you giving IV push or IV piggyback came through as a question as well?
Yeah, this is given as an infusion over 30 minutes. We try to avoid giving IV push because there's potential increased risk of hypotension, respiratory depression that way.
Gotcha. All right. Thank you very much for your time and your presentation. Very interesting.
Thank you.
All right, we'll go on to, here's our benzodiazepine conversion.
Yeah.
It's slides. Okay, all right. We're moving on to our last presenter, Dr. Wood. Take it away.
All right, thank you so much. Today I'll be talking about the early versus late anticoagulation initiation after TIA or acute ischemic stroke in patients with atrial fibrillation. Next slide, please. We have nothing to disclose. Next slide, please. The objective of this presentation is to describe the benefits and risk of early versus late anticoagulation initiation after TIA or acute ischemic stroke in patients with atrial fibrillation. And as we know, atrial fibrillation is the most common cause of sustained cardiac arrhythmia, and this can contribute to the formation of a thrombus in the left atrial appendage, which could subsequently lead to stroke. The CHADS-2-VASc score measures stroke risk in atrial fibrillation, and you can see the components over on the right-hand side of our screen. In the 2023 atrial fibrillation guidelines recommend anticoagulation in patients with a CHADS-2-VASc score of at least 2 in males or at least 3 in females without contraindications. Next slide, please. However, the timing of anticoagulation initiation after an acute ischemic stroke or a TIA really requires a balance of thrombotic and bleeding risks. Thrombotic risks are increased, especially during that first week after an acute ischemic stroke. The 2019 guidelines for the early management of ischemic stroke recommend a 4 to 14-day window post-ischemic stroke for the initiation or restart of anticoagulation, but they don't provide any guidance on when to restart within that window. There have been two proposed rules. So one is the 12-day rule, where you would start anticoagulation at day 1 for a TIA, day 3 for a mild stroke, day 6 for a moderate stroke, and day 12 for a severe stroke. And more recently, the 4-day rule has been proposed, which actually would restart anticoagulation at day 4 for severe strokes. Next slide, please. Looking at the literature, we have two recent trials. The timing trial looked at adults with atrial fibrillation and acute ischemic stroke, and they compared early versus delayed anticoagulation with the timing as shown on the screen. Their composite of new acute ischemic stroke, symptomatic ICH, or all-cause mortality showed that early anticoagulation was non-inferior to delayed anticoagulation. And next slide, please. And the Elon trial in 2023 was a similar trial. The differences here were the definitions of early versus late, as described on the screen, and also they identified the severity of the stroke by imaging. Their composite of new acute ischemic stroke, systemic embolism, major extracranial, symptomatic intracranial hemorrhage, or vascular death in 30 days showed no difference between early anticoagulation and late anticoagulation. Next slide, please. The objective of this research was to compare the efficacy and safety outcomes with early versus late initiation of anticoagulation after acute ischemic stroke or TIA in patients with atrial fibrillation. Next slide, please. And our primary outcome was a composite outcome based on the Elon trial of recurrent ischemic stroke, systemic embolism, major extracranial or intracranial bleeding, and or mortality within 30 days of stroke onset. And our secondary outcomes were all of those individual components separated out individually. Next slide, please. This was a retrospective cohort study with a matched analysis. Our patients were matched based on age, sex, stroke severity, new onset versus pre-existing atrial fibrillation, and the initial route of anticoagulation, whether that was parenteral or oral. And data were collected from admissions between January 1st of 2020 and July 30th of 2024. Next slide, please. Patients were then allocated to early versus late anticoagulant arms, and you can see those described over in the chart on the right. We based these on the 12-day rule, where early anticoagulation was defined as before this timeline and late anticoagulation was defined at or after this timeline. And there were two pre-planned subgroup analyses based on the initial intervention and the stroke severity, and we'll talk about those in a bit. Next slide, please. This research was performed at the Lee Health System, which consists of 5 acute care facilities. Most of our patients, I think 80% of our patients, were at Lee Health Gulf Coast Medical Center, which is an accredited comprehensive stroke center with neurointerventional capabilities that houses the Neuroscience Institute with 26 neuro ICU beds. Next slide, please. Our patients were included if they were adult patients admitted to any of our adult hospitals for a TIA or acute ischemic stroke with a concurrent diagnosis of atrial fibrillation. They were excluded if they were on anticoagulation for another indication besides atrial fibrillation, if they had a history of severe bleeding, or not with a non-reversible cause or recurrent falls within 6 months, if they had mortality or hemorrhagic conversion before anticoagulation, or if they were at a high risk of bleeding. We also excluded patients with positive pregnancy tests and acute aortic dissections. Next slide, please. 153 patients met our inclusion criteria. 3 patients were excluded for hemorrhagic conversion or mortality before anticoagulation. This left us with 105 patients in our early anticoagulation group and 45 in the late anticoagulation group. And of these patients, 39 patients from each group were matched in our matched analysis. Next slide, please. All statistical analyses were performed according to the data collected. Next slide. And when we look at our patient demographics, we can see overall both of our groups were well matched. We have a couple differences. Our renal function was statistically significantly worse in the late anticoagulation group. And next slide. And in our late anticoagulation group, our patients were more likely to not be on anticoagulation prior to admission. And in the early anticoagulation group, our patients were more likely to be on apixaban, specifically for anticoagulation for atrial fibrillation prior to admission. Next slide, please. When we look at our stroke severity, the big thing you'll notice is that most of our patients were TIA patients, so about 50 to 60% of patients in each group, but we did have a number of mild, moderate, and severe stroke patients as well. Next slide, please. And when we look at our initial intervention, probably because most of these patients were TIA patients, we'll note that most patients did not receive systemic thrombolysis or thrombectomy, but there were several patients in both groups as well. Next slide, please. When we look at the timing of timing from stroke onset to anticoagulation, we'd expect this would be statistically significant based on our definitions, but we can see in our mild, moderate, and severe strokes, this is also clinically significant, where we would see a upwards of 3 or 4 times difference between our early anticoagulation group and late anticoagulation group. Next slide, please. And then when we look at our initial oral anticoagulation post-stroke, we'll see that most of our patients were started on apixaban post-stroke. This both drives with our PTA pattern with the early anticoagulation and our literature recommendations. Next slide, please. Looking at our primary outcome in our unmatched cohort, we saw an increase in the composite of recurrent ischemic stroke, systemic embolism, major extracranial or intracranial bleeding, or all-cause mortality within 30 days, and this was statistically significant. Next slide, please. However, when we looked at our matched analysis, we still saw an increase in this composite. However, the statistical significance was attenuated. Next slide, please. We saw similar patterns in our secondary outcomes, and you can see that in the unmatched cohort, the increase in recurrent ischemic stroke specifically was higher in our late anticoagulation group. That was statistically significant. We saw no other differences between the other components of the composite outcome. And next slide, please. And in our matched cohort, we do not see a statistical significance between any of the outcomes, although we do still see an increase in recurrent ischemic stroke. Next slide, please. Looking at our pre-planned subgroup analyses, if we look at our initial intervention, we do see that our patients that did not receive systemic thrombolysis or NI procedure did have a statistically significant increase in the composite outcome in our late anticoagulation group. And next slide, please. And we see a similar trend in our stroke severity, specifically in our patients with a moderate stroke, which in this study was defined as NIHSS score of 5 to 15. Next slide, please. Strengths of this study are that we examine the safety and efficacy of the initiation of anticoag after both TIA and acute ischemic stroke, where previous studies really only looked at acute ischemic stroke. We included patients with thrombolysis and our neuroendovascular intervention, and we performed a matched analysis to minimize any potential confounders. Limitations of this study include its retrospective design and that we were limited to the data accessible to our health system for our outcomes. Patients were only included if the initial NIHSS and the time of symptom onset was documented, which may have limited our patient pool. And because we had a large number of patients with TIA, this study may have limited generalizability to severe strokes. Next slide, please. In conclusion, the early initiation of anticoagulation was associated with a significant reduction in the composite outcome in the unmatched analysis, and this was mainly driven by a reduction of the recurrent acute ischemic stroke. Remember, though, we saw no significant differences observed between groups within the matched analysis. That early initiation of anticoagulation was associated with a similar risk of bleeding as the late anticoagulation group in both unmatched and matched analyses, and the patients were more likely to experience the composite outcome if anticoagulation was initiated after the 1-3-6 12-day rule, especially in patients who did not receive systemic thrombolysis or neuroendovascular intervention or those with moderate strokes. Next slide, please. So our recommendations going forward is that a anticoagulation initiation earlier than the 1-3-6 12-day rule is appropriate and should be recommended in most patients, especially those who do not undergo thrombolysis or neuroendovascular intervention or those with moderate stroke. And you can see that timing highlighted in the table below. Next slide, please. I'd like to thank my research team for all of their help with this research project. And next slide, please. So our self-assessment question, which of the following are true based on this study's matched analysis comparing early versus late initiation of anticoagulation post-TIA or acute ischemic stroke in atrial fibrillation patients? And you can reveal the answers. I'll give you a couple seconds to read them. And then we can move on to the answer. All right, and so in the matched analysis, there were no significant differences between groups in the composite or the secondary outcomes. Next slide, please. And that is all I have. I'd be happy to take any questions.
Great job.
Thank you.
All right, any questions for Dr. Wood? All right, hearing
I have
none.
a question.
Oh,
Thank
please.
you for a nice presentation. Do you have any data on Pradaxa?
Pradaxa specifically?
Did you have any patient on Pradaxa?
I don't. If we had any, it was a very small amount. Let me double check real quick.
I think would be very minimal.
Yeah, it was minimal, if any. Let's see. We had a couple PTA, so we had about 2% in each group. And then our initial oral anticoagulation afterwards, it was the same percentages. So it was the only people on Pradaxa were the people that were started prior to admission on Pradaxa. And at least in our health system, that is generally due to a cost barrier. Pradaxa is kind of our go-to anticoagulant for patients that have no other access to any sort of insurance.
So based on your data, if they came in with these drugs, right, and they go home, they resume these drugs, even they may fail?
So in some patients, yes, but if you look at the therapeutic failure, that was very limited. And so we defined therapeutic failure when they required an oral anticoagulation switch based on provider. Anecdotally, it's not included in any of my data. A lot of our patients that came in with acute ischemic stroke or TIA were those patients that stopped the anticoagulation for 2 or 3 days because of another procedure. Or they were holding it because of some other reason, and then they ended up coming in with strokes. So it wasn't necessarily that it was a failure of the oral anticoagulant necessarily.
Okay, thank you. Maybe it's non-compliance, or like you said, maybe
We
they're
had a bunch
holding
of
for
that
some
too.
procedure. So
Yeah,
that might be a
hard to-
limitation
Absolutely,
for the
yes.
study. But
Yeah.
thank you, great work, thank you.
Thank you.
All right, any other questions for Dr. Wood? All right, hearing none, we will thank everyone for their attendance this evening. We would just want to let you know that everyone will receive an email from Tamika regarding procurement of CE credit, and we are also going to send out a PDF of the slides for those that were interested in seeing any of the results. So once again, we'll thank the speakers for sharing their research. Well, thank you for attending, and we will also let you know that there's going to be another session in 2 weeks highlighting some research from the Memorial and Jackson health systems. So look out for emails regarding registration for that, and have a great night, everyone. Thank you.